Genova. It will again talk about complex malformations of craniovertebral joint.
Un saluto ai moderatori.
Thank you to the team, and good morning, everybody. I'd like to thank you, Dr. Valentini, for this invitation. I'm going to talk about remarks about complex craniovertebral junction disease to avoid repetition. Looking at it from a different stance, let's try and look at the cranial cervical junction area, which is a very fluid area and it's a very crowded area. It's very often confused, and we're going to look at this situation through a series of examples. And it's very slippery ground, as I will see. Therefore, you can see that here you have these things. The first thing is bone anomalies that I'm going to look at. And the first three chapters, if you like, have to do with localized specifics to the joint problems, and then also systemic disease involvement is the fourth. So we have an overview here of problems which have to do with the bone, involve the bone. The hospitalization of C1 is rare, but you can see the structural anarchy at the level of C1, C2. The problem is that very often we have stenosis of the foramen magnum together. The odontoid bone, you can see this. Well, you see this rarely, but not as rarely as we think. We don't understand really if this is congenital, acquired, or both. And intrinsically it's stable, and therefore it can have acute neurological worsening, as in this case. This is an example of mild severity. You can see flexion and extension, you can see the joint instability, or it can be dramatic. A 12-year-old boy, tetraplegic, operated on, but there was no recovery. Another idea, basilar invagination. Here it seems that the cranial basal components are sucked upwards, and this displacement can cause neurological problems every time the skull moves. So you have, again, something which has to do with that link, and we heard about that before. This is C1, C2 instability, very rare, and it's a spondyloepiphyseal dysplasia. You can see the C1, C2 situation. We have a small fixation with sublaminar fixation, very satisfactory results. Similar case, you can see limited fixation has been carried out, and one case that we treated with bone arthrodesis and with a backbone graft. Another interesting chapter is achondroplasia. You all know this. In the last 10 years, this is something that we're seeing increasingly frequently and earlier on, and there is a center, in fact, perhaps there's a concentration here. But anyway, the thing to point out is in about 30% of cases there is a stenosis of the foramen magnum, and this can cause neurological deterioration, which is acute, with amnesia, dyspnea, and cardiac and respiratory arrest. So you have to be very careful when you have a child like this, especially a very young child. Here you see certain severe stenosis of the foramen magnum. Compression is caused, and here you can see on the left there's also cartilage stenosis with the bone windows. You can see that the bulb cord passage is very, very narrow, and therefore I think here you should operate on, even I would say especially in asymptomatic cases. This is the post-op picture. You can see the compression. You can see the post-op decompression. Another case, the the degree of stenosis varies. It can be lateral, it can be posterior, or there can be asymmetric spurs which compress the cord. It's fundamental that one never moves the neck. You avoid flexion and extension, and you intubate these children. Monitoring is all important because, again, even a small movement can cause functional problems. You can see this asymptomatic child, and the compression is very obvious, and we agree very much with what Dr. Sala was saying. In other words, neurophysiological monitoring, especially for position changing. This is important. Very often we have to change, even very slightly, the position of this patient because we see change in the evoked potential. So I would recommend this sort of approach. You can see decompression. It's difficult. The border of the foramen, occipital foramen, is invaginated under the atlas, and therefore you can't flex the head. It would be much easier to do that, but you can't. So very gradually you remove the border of the occipital foramen. It's very delicate because there's no space between C1 and the occiput. Another area is mucopolysaccharidosis. There was an interesting presentation yesterday, especially with regard to the hurlers, ski, and mortality. We have less experience here, but you have to bear in mind the accumulation of mucopolysaccharides in this area. Down syndrome, there is the risk of instability because there is excessive laxity of the transverse posterior ligament, and therefore you can see here there's chronic neural deficit, and you can see this MRI very clearly, and therefore you have to go for surgery to try and stabilize and decompress. Here we reduced the luxation, and then we did anterior decompression to remove the odontoid, and excellent improvement compared to the first case, even if in fact you see that the cord is still not doing that well. This is a spondyloepiphyseal dysplasia. You can see this accordion type of appearance, and you can see the results of decompression. Another aspect, it's rare, very difficult to manage trauma. You can see two cases, rotatory luxation C1, C2. You can see the neck is anomalous. You can see you've lost the normal ratios at the cervical level, and even if you can reduce in anesthesia the luxation, but it tends to relapse, so you have to go for surgical fixation. You have to keep this orthosis for a certain amount of time, and you can see the loss of the articulation between C1 and C2, and you can see the fracture of the mandible, which was treated in fact with an external orthosis. This was difficult. This case, 2-year-old child came asymptomatic. We carried out an X-ray just because she had a bump on his head, and we saw this sort of fracture in C2, a very overt fracture, and we were very surprised given the age of the child, and therefore we did a plaster which we made ad hoc to try and keep the atlas in position. We created a halo for the little girl, and we put her into this plastic plaster, and we contained the fracture, and then we did a fusion with a bone. For 6 months we kept her in this, and for 6 we put her into a thoracical chin brace, and after that she did very well. Tumors in this region Just to change subject a little bit, this is a case of a little girl who came because of cervical problems. You can see an enormous chordoma of the clivus, both lateral and going outwards. A technical problem this presented. We decided to do posterior fixation, to have a transoral approach first of all, and then afterwards 2 approaches with the maxillofacial surgeon, submandibular approach, and this allowed us to reduce the mass of the tumor. It wasn't possible to remove it all. It was a very difficult, delicate operation, but this is the result, and we were able to then go to we are still waiting to see how this case in fact evolves. This is a neurofibromatosis. You can see a meningioma in the cervical. You can see the signs of the previous signs of another tumor, an F1. You can see the result. And this was to underline, as Sola said before, this was done in March, and you can see the kyphosis, which in fact has been caused and which in fact gives us a certain degree of concern. This is a tumor of the bulbar area. This is a ganglioglioma that we weren't able to solve. This was a hard, calcified, large tumor, so we could practically only do a biopsy. It was negative, and it was a whole spinal tumor. This is another person who came with dysphagia. We thought it was a Chiari, but it was in fact a huge tumor, and the symptoms were that of a Chiari. After the surgery, we then had a relief of symptoms, and however this is the scoliosis that in fact was caused, as was in fact said before. Late effects. This is the tip of the iceberg. Very often in fact what we see is much less than what is there. You can see here some cases of progressive deterioration of in various areas, dwarfism, various malformation, and things worsen over time, very often dramatically. This is a kyphoscoliosis in NF1 over time. After several years, you can see deformity of the cervical spine with clinical signs, hence complex treatment required. Obviously, here we have to deal with this with orthopedic surgeons. You can see after some time, this is a person of 11 years, children who have either degenerative disease or syndromic disease, or after laminectomy. The results nonetheless are good, and the little girl is not perfect, but her posture is quite good. Neural malformations, this is the last thing, because it helps me to get along the track of what we're talking about. There are other things which are involved, not just Chiari, a dandy walker, for example. Here we have compression, displacement, and ischemia, which is caused, and similar cases with different anatomic situations. Here we can't do endoscopic treatment. On the other side we can. So where possible we do treat endoscopically. If the aqueduct is stenosis can be treated, we in fact do it, and this is a very obvious case. I always show this because it's an example of where, alongside the fine morphological result, also there has been, however, a psychomotor retardation. The child has still remained retarded, so the morphological condition not always coincides with good clinical results. Another complex case. We didn't diagnose it at the minute. We thought it was an arachnoid cyst, and then the patient came with tetraparesis and respiratory problems, came to the ER, and in fact we realized it was a cyst, and histology showed that in fact GI tract epithelium was involved. There's a galaxy of Chiari, which is very clear from what we've heard in the last couple of days. In fact, it is a galaxy. Simple Chiari and the bulbar Chiari, where there's a kinking, and then also we have cases where there are mind symptoms, and scaphocephaly and Chiari 1. And I think there are two problems, trigonocephaly, scaphocephaly. These are all things that we have to take into account. One thing that's important is that in a pediatric patient, you probably very often, in fact, want to protect the child radiologically and eliminate CT scans and the radiology where possible. And clinical examination is in fact attempted, and we do our MRI because the parents want to know really the extent of the damage. So as a result, apart from this child who had dysphagia and torticollis, we in fact did this examination. Here we have typical cases of a small posterior fossa, and then again here we have cases like this where certainly a series of investigations are necessary to exclude a Chiari. This is an interesting case. This was in fact studied by our geneticist. These were two brothers. This is the second little boy, and he had synostosis, and the interesting thing is you can see the cranium. Having had the first child who was sick, we did the MRI prenatally, and you can see that Chiari is not, in fact, a congenital problem. It's due to the bone deformation, and soon after birth, 1 month, you can see the Chiari appearance. So it's not a congenital disease, this, but it's due to a bone anomaly, which in fact then triggers Chiari malformation. Of course, we reconstructed the cranium, and both in terms of morphology and flow, we've seen improvement of Chiari and flow and venous outflow. This is another case. Very difficult case. The considerable bone of the base of the skull. We didn't want to cause collapse of the structure, so we carried out a small biopsy to find out what it was. So we had this cystic angiomatosis, and we treated with radiopathy and radiotherapy, and the child is now stable. This was not a diagnosis. A 3-week-old child with dysphagia in resuscitation, swelling, which was retropharyngeal that was seen. You can see this hydrocephalus is a small Chiari 1 biopsy. We couldn't make a diagnosis here, really. As our consultant is Mr. Marsiglia, who is an expert in resuscitation of neonates, and he comes from Marseille. And he took a biopsy. He couldn't define it, what this mass was, and the mass in the meantime continued. We dealt with the hydrocephalus, but the Chiari worsened. I think we will operate on him, but we're waiting to see whether the spine is going to stabilize, because we're really scared of destabilizing. It's a sort of pre-spine hematoma, I can describe it as. You can see it's at the level of the cranium. You can see the sort of appearance. This is a ghost bone disease, Gorman's. This, you can see the consequences. This is a dural fistula associated with angiomatose and dermatosis. We carried out embolization. Chiari 2, this has already been dealt with previously. I'd just like to say that we never, in fact, touch this space. We don't widen the occipital foramen if there is sufficient space between C1 and C2. These are all the various images. This was given from Sutton Schwartz in Philadelphia. We don't have experience of this. This is spina bifida together with Chiari 2. I know that there's a trial ongoing to assess these, whether this is a chance finding or it has a scientific basis. This is a very severe case, and on the bottom right, minimum signs with small Chiari. Chiari 2, this one, not all Chiari 2 have open situation. You can see that here we have subcutaneous mass. Now, here, myelocystoceles. Here we have the cervical laminectomy. In the Chiari 1 situation, we have herniation of the tonsils, whereas it's the vermis in Chiari 2 which herniates. So if you like, that's the difference. This is a Chiari 3. Severe. Fortunately, we don't see practically any of these anymore. It depends on what point the embryogenesis, what embryo pore is involved. Mesencephalic one in Chiari 3. In number 4, we have cerebellar hyperplasia of severe type. To conclude, what is our attitude? We have about 240 cases diagnosed of Chiari 1. We have operated on 51%, more or less. So we have a certain number that we have not operated on. We wait and see, and they don't have flow anomalies, and we of course follow them up. Osseous ligamentous decompression. When we don't have flow, decompression plus duroplasty, where we have bulbomedullary dysfunction or bulb problems, as you can see on the slide. We have a change in strategy. These are patients that we used to monitor, and from symptomatic when they became symptomatic, and then either from the clinical point of view or because of the flow. And then the second step is when surgery, just bony decompression is not sufficient, then we go for the duroplasty as well. Osseous ligamentous compression is only part of the treatment. This is a first step, and we already put that into the informed consent of for the family, so the family knows that there is this possibility that we might have to go back in with all the attendant risks. Last point. We've changed or rescheduled deep compression in the presence of associated or concomitant local or systemic pathologies and so on. Last point, the choice of surgical priorities, whether to go for hydrocephalus first or what. We go for the disease we think is most prevalent and important, and treat the malformation. And this when we have symptoms, very specific symptoms. Thank you. We have time only for one question. It's a great pleasure to have Professor Moneto here, who is the councillor with special responsibility for health matters of the city of Milan, and also we have the president for who is in fact involved in the best experience. What do you do? There's one question. If you have asymptomatic patients, I mean, how do you deal with them? How do you get them to stay alive? If that you haven't in fact operated on, we say live normally. Obviously, you mustn't have any violent activities that might influence the cranium, the skull. There is a risk. If you don't have symptoms, of course, you have to balance risks. I know you don't agree. I mean, otherwise we'd have to do something about all of them. I mean, I agree with what Jamie said before. I feel like there's a contradictory attitude vis-a-vis Chiari too, because in fact otherwise you would have to prophylactically go for surgery for all of them. I mean, how come we are so careful with Chiari 1, whereas in Chiari 2, there's a contradiction there. Well, we can perhaps go back to this in the afternoon.